Hello, this is Dr. Brian Plato from the Norton Neuroscience Institute in Louisville, Kentucky. And I'll be talking to you today about a very timely topic that, quite honestly, we are learning about as we go. So this is the relationship between COVID-19 and headache. So the question is there something unique about the SARS-CoV-2 virus that is triggering headache, or is it similar to other viral infections and how that plays a role in triggering headache and migraine attacks? So we know that for many viruses or many infections, a common symptom that patients will report is that they have headache as a symptom of it. And so is there something that is different about this particular virus and how it affects headache, or is this just sort of similar to other viral infections? We don't know yet. So the things that we think we know, so it certainly looks like associated with COVID-19 is that there are some associated neurological symptoms. So increased rates of stroke, fatigue, psychosis, so sort of delusional or other thoughts, and some dementia-like cognitive impairment, and then headache as a potential symptom. So it's looking like definitely some neurological complications along with COVID-19. And so why? Well, we don't know, but perhaps it looks like the particular receptor, the ACE2 receptor, that the SARS-CoV-2 virus uses to enter the cells is found on the brain, particularly around the brainstem. So is it possible that virus is affecting the brain directly? Not sure. Or is it through secondary pathways, such as through autoimmune responses? Again, I don't think we know this. So I think we do know that the MRI scans of some patients with COVID-19 demonstrate some changes that are consistent with inflammation of parts of the brain. And so giving us a suggestion that there are some effects that we're seeing in patients who have COVID-19. Here are some MRI scans that are not patients that I have treated, but MRI scans that have been reported of changes that are seen basically of inflammation of parts of the brain. For example, you see in the cerebellum, deep white matter, or in the brainstem in the picture below. So we're seeing that in some of these patients who exhibit neurological symptoms associated with their infection, that we see some evidence on their MRI scans of changes in the brain. What are the long-term effects? This is obviously unknown. We are talking about a disease that has only been seen in humans for a short period of time. So we don't know what the long-term effects are. In one patient who I have seen that had on MRI findings of inflammation of the brain, within about a month, repeat MRI, the brain returned to normal. So maybe that's a good sign in that we will not necessarily be seeing long-term neurological impairments associated with this condition. Now, what about specifically to migraine? So it is well known that people with migraine are more likely to have migraine attacks when they're sick with infections, particularly when they're having fever. So we'll see this all the time. A patient of ours that has a history of migraine, they get sick with, whatever sort of run-of-the-mill infection, and they start having more migraine attacks. And then they get over that illness, and they sort of go back down to their baseline. And keep in mind, migraine is quite prevalent. So 12% of the population having migraine. So that means that there's potentially a lot of people who are going to be exposed to COVID-19 that have a history of migraine that may see this increase in headache. So it's not surprising that this is something that's getting talked about. So as more people with migraine become infected with the SARS-CoV-2 virus, then it's more likely that they're going to be experiencing headache as a symptom. And it may be possible that some individuals, their only symptom is an increase in their migraine frequency. So the things to look at would be are they having perhaps an otherwise unexplained increase in their headache frequency or a change in their headache features? So from helping to take care of a lot of people with migraine, I'll find that individuals who have migraine know what their sort of normal migraine attack looks like. And if they have a change in its features, they're aware. They'll tell you, this isn't my normal migraine, in terms of how it hurts or where it hurts or how severe the pain is. They might be able to tell you that there is that change. So, as I said, it might be possible that someone who has a history of migraine may have as their only symptom of COVID-19 an increase in headache. So this creates a real challenge. So, if you have an increase in migraine, should you go and get tested? Should you avoid being around people? I don't know. No, probably not, unless there's a significant change in the features of headache or other symptoms such as fever are present. Now, what about some circumstances particular to individuals who have migraine? So, NSAIDs. So, in early March, there were starting to be some reports and concerns that maybe NSAIDs could alter the effects of that ACE2 receptor and maybe have effects on the severity of illness if someone was infected with SARS-CoV-2. And there were some concerns that if someone was taking NSAIDs, it might mask some of the early symptoms, such as fever, and so that patients weren't presenting until later in the course of the disease. So a lot was being talked about with the potential use of NSAIDs. And in mid-March, the French Minister of Health recommended not using NSAIDs to treat fever in patients with COVID-19, instead using paracetamol, which would be like the equivalent of acetaminophen here in the United States. And so then it was also announced that NSAIDs might worsen the clinical conditions of patients with COVID-19 based upon the evaluation of 4 patients affected by it. And I should pause here for a moment and highlight how we're watching science evolve here with a disease. So, based upon very limited numbers of patients, these recommendations were made. And these recommendations made their way to a lot of patients and I think created a lot of concern of, what should I do in treating myself? I want to obviously do whatever I can to keep myself in the best possible condition. And so, should I take this advice and avoid using NSAIDs? Should I not? And that really is hard when we're faced with this emerging and developing medical condition. So, as you know, individuals with migraine rely on NSAIDs heavily to treat their migraine attacks. And we know that ineffective treatment of migraine might lead to the worsening of migraine. And so this creates a challenge of, if I know that, for example, ibuprofen is effective in terminating my migraine attack, but then there's these warnings that maybe I shouldn't take ibuprofen, then what should I do? Because we certainly don't want migraine to not be treated and then, continue on into subsequent days and lead to this idea of the chronification of migraine. So it really creates a challenge of whether patients should continue using their NSAIDs or not. Ultimately, though, it looks like NSAIDs don't worsen or alter the outcome of patients who are infected with SARS-CoV-2. So at this point, I am not advising patients who use NSAIDs to treat migraine to stop or alter their use. Now, what about this big one? So Botox. So it's been talked about in other talks here today that Botox is approved by the FDA for the prevention of migraine. Botox is typically administered every 12 weeks. And many patients who receive Botox will notice, and I'll show you this here in a minute, that about 1 to 2 weeks before they're due for their next dose, that they start to have an increase in headache frequency. And so, as around the country, elective procedures started to become canceled, there was this question of, well, how elective is Botox in treating migraine? So, with no one really knowing what the right or wrong answer was, I think a lot of centers around the country either stopped Botox altogether, or like what we did here was we significantly reduced the numbers we were offering. And the problem is that the longer that patients go without Botox, the more likely they are to have more headaches and more severe headaches. And so this is a recent study that came from the journal Headache showing this so-called wear-off effect. So what you can see is on the top chart is this is a depiction of headache days per week. And so you can see that after the injections, the number dips down. And then as you reach out to weeks 12 and 13, the numbers go back up again. The next graph is the frequency of moderate or severe headache. Similar trend. So you can see that as Botox is wearing off, these numbers go back up again. And then the final graph is for the number of days that patients are having to take medication to treat migraine. So we know that as patients become due for their next dose of Botox, we expect them to start doing worse, okay? And the problem that this creates is that as patients are doing worse, they may end up getting to a point where they need to go to an emergency department or an immediate care center, which in my opinion certainly creates more risk than coming in for Botox. So, you know, how we do Botox in our practice is we have one area that all the patients are coming for Botox, and so probably less likely to get exposed to a respiratory illness coming to an area where patients are just coming for Botox treatment versus going to an immediate care center or an emergency department. And so during this time, many patients were switched. You know, if someone had been on Botox for a long time, maybe we decided to stop Botox and switch to one of the anti-CGRP antibody drugs that can be given at home. So the ones given at home include Aimovig, Ajovy, and Emgality, and you've heard about those from others here today. So I think going forward, if we start to see worsening of infections, I think a real consideration would be taking into account that Botox, we know that their medical condition will worsen if they go without it. And so taking that into consideration for, you know, what really constitutes elective procedures or procedures that need to be continued. Now, what about this one? So new daily persistent headache. So new daily persistent headache is something that was initially described in the mid-1980s. Essentially is patients who develop headache one day and it persists for a period of time greater than 3 months. This is a type of headache that is always present and oftentimes does not respond to medical treatments. So really, as a headache specialist, this is the type of patient that when we see them, you know, we really are worried about what the prospects for improvement are going to be. Many patients with new daily persistent headache have a triggering event. So whether that's an emotional life event or some other event that then is the triggering of their new daily persistent headache. But one of the most commonly identified triggers is a respiratory tract infection, typically viral. So thinking about COVID as a potential trigger for new daily persistent headache, 13% of patients from a Spanish study presented with headache as the main symptom. And so the question will be is, when you go out 3 months from their initial onset of headache, how many patients are going to continue to have headache? And does treatment early affect the long-term course of headache? So what have I seen? So I've definitely seen patients who have come in with the new onset of daily, continuous, persistent headache. And have I seen this at a higher frequency than I typically would? I don't know. You know, maybe I'm paying more attention to it, and so as a consequence, you know, more in tune when I see these patients. But I can't say that I've seen, you know, significantly more numbers of patients. What am I doing? So if someone is presenting with what looks like new daily persistent headache around the time that the COVID-19 pandemic has been ongoing, I am testing for antibodies against the SARS-CoV-2 virus. I have not yet diagnosed anyone with COVID-19 related new daily persistent headache. I guess one question is, when you're seeing them months later, is what's the reliability of antibody testing and making that diagnosis? And, you know, that's, you know, I think we'll get to that at some point in the future. So what are the takeaways here today? So headache is definitely a symptom of COVID-19. It is associated with many viral infections. And I think people with a history of migraine may be more likely to have headache associated with COVID-19. If someone's experiencing new and persistent headaches or a significant change from their previous pattern of headaches, might consider testing them for COVID-19. I do not think it looks like we need to avoid using NSAIDs or other medicines that we would typically use to treat migraine. I think a year from now, we'll have a better sense of how this virus is affecting our brains and what the effects are of headache as one of its predominant symptoms. So thank you very much for joining me. Again, I hope next year we're seeing each other live and in person for our Norton Neuroscience Institute Expo. But I hope you enjoyed the information that you learned here today with us. I hope it was beneficial to you. And